Osteoarthritis is a very common problem worldwide. According to global data from 2020, 7.6% of the population is affected by osteoarthritis. That's around 500 million people. And in the near future, this number is expected to double by 2060. It's also increasing among populations in high-income countries, and surprisingly, the onset is occurring earlier than in the past. The main risk factors for osteoarthritis include being female and over the age of 50, as well as obesity or being overweight, a history of joint trauma, genetic predisposition, and even occupational stress. Another significant risk factor for hip osteoarthritis is acetabular dysplasia. Soccer players are also at higher risk of developing osteoarthritis at a younger age due to injuries sustained during play. Undergoing a meniscectomy increases the risk of knee osteoarthritis compared to meniscal repair. On the other hand, regular physical activity, when done correctly, can reduce the risk of developing the disease. As for pain, sometimes patients with severe radiographic signs of osteoarthritis report no pain at all. They're asymptomatic. Conversely, some patients may have only mild osteoarthritis on imaging, but experience significant pain. Certain conditions, such as asthma or atopic dermatitis, may increase the risk of pain due to the possible role of mast cells in the progression of OA. Other contributing factors include sleep disturbances, depression, low back pain, and cardiovascular disease, all of which are associated with increased pain perception in osteoarthritis. OA typically presents as joint pain that occurs during activity or exercise and usually improves with rest, especially in the early stages. When stiffness is present, it generally lasts less than 30 minutes, rarely more than an hour. In more severe cases, pain may also be experienced at rest or during the night. On physical examination, you may observe muscle wasting, joint crepitus during movement, joint effusion, the presence of osteophytes, tenderness, and stiffness with movement. The pathophysiology, in simple terms, begins with macrophage activation. Whether triggered by trauma or genetic factors, macrophages begin to release interleukin-8, TNF-alpha, and interleukin-6. This initiates immune modulation and also upregulates VEGF and possibly selectins, promoting angiogenesis. As a result, T cells and neutrophils are recruited into the synovial fluid and joint space. Subsequently, chondrocytes respond to the inflammatory signals, including interleukin and TNF-alpha, by entering a catabolic state. This disrupts joint homeostasis, as catabolic activity outweighs anabolic repair, ultimately leading to joint degeneration. Chondrocytes begin to proliferate and produce matrix metalloproteinases, MMPs, enzymes that degrade the extracellular matrix within the joint. This leads to the breakdown of cartilage. As the cartilage deteriorates, it begins to fibrillate and develop fissures, eventually exposing the subchondral bone. The subchondral bone acts as a shock absorber, but in response to cartilage damage, it increases angiogenesis and activates osteoblasts. This leads to bone sclerosis, the formation of cysts, osteophytes, and bone marrow lesions, all contributing to the pathophysiology of osteoarthritis. It's important to consider differential diagnoses when evaluating osteoarthritis, as there are various possible underlying causes. In cases of crystal-induced arthritis, patients may experience acute pain in small joints, typically the first metatarsophalalangeal joint, but also the elbow or wrist. The joint may be swollen, red, and warm to the touch, with symptoms often presenting at night. On examination, crystals may be detected in the synovial fluid, and laboratory tests typically show elevated CRP and lymphocyte levels. In aseptic arthritis, synovial fluid analysis also reveals elevated neutrophils and lymphocytes. However, it is usually accompanied by a large joint effusion, redness, and a positive culture from the synovial fluid. Rheumatoid arthritis is an autoimmune condition. It is typically associated with elevated levels of rheumatoid factor, ANA, and anti-CCP antibodies. Its presentation is usually symmetrical, not limited to one side, and morning stiffness often lasts longer than 30 minutes. In the case of osteoarthritis, diagnosis is primarily clinical, provided there are no atypical features. It is usually considered when the patient is over 45 years old, reports pain related to activity, and experiences morning stiffness lasting less than 30 minutes. Imaging, such as X-rays, can be used to assess the osteoarticular system and to grade the severity of osteoarthritis, but it is generally not indicated unless grading is specifically needed. If you want to evaluate not just the bone, but also soft tissues and the entire joint structure, you can use ultrasound, MRI, or CT scans. For differential diagnosis, blood tests are important, including a complete blood count, ANA, and anti-CCP, to rule out autoimmune or inflammatory conditions such as rheumatoid arthritis. If the patient is not a candidate for surgery, conservative treatments can be considered. Now let's move on to treatment. Pain management in osteoarthritis addresses three main issues: pain reduction, preservation of joint function, and reduction of inflammation. Pain can be categorized into two types: nociceptive and neuropathic. Nociceptive pain is typically inflammatory or mechanical in nature. Neuropathic pain may develop early or later, depending on the individual's response. Some patients experience heightened sensitivity and hyperactivity of cytokines within the joint, leading to a process known as sensitization. This begins as peripheral sensitization with an increased cytokine response and can progress to central sensitization, involving changes in brain structures such as the cerebral and basal nuclei, along with dysregulation of the body's pain modulation systems. The cornerstone of pain management includes physical therapy and weight management to address modifiable risk factors. In patients with joint prostheses, treatment options include pharmacotherapy, genicular nerve radiofrequency, and neuromodulation. If not, other options include joint injections, such as intra-articular hyaluronic acid or corticosteroids, which can also be combined with radiofrequency treatments or neuromodulation. Drug therapy typically involves NSAIDs, opioids, and anti-inflammatory agents, depending on the case. Topical NSAIDs are the first-line treatment recommended by all major European guidelines. Paracetamol, acetaminophen, is also commonly recommended, but only for short-term use due to the risk of complications such as hepatotoxicity. Systemic NSAIDs should only be used when topical NSAIDs are ineffective, and even then, for a limited duration and always in combination with a proton pump inhibitor, PPI, to protect the stomach. Opioids should be considered only as a last resort in pharmacological management, typically weak opioids like tramadol or codeine. Strong opioids are generally not recommended in most clinical guidelines. Adjuvant medications such as nutraceuticals can sometimes be helpful, especially in the early stages or when the patient experiences side effects with standard therapies. Corticosteroid injections are sometimes not recommended, but when they are, their use is limited to short-term symptom control. Repeated corticosteroid injections are associated with potential adverse effects and should therefore be used cautiously. Intra-articular hyaluronic acid is a relatively recommended option in cases where other treatments have failed or when the patient is not a candidate for surgery. Here is the therapeutic protocol. In patients with a total knee arthroplasty, TKA, the available options are genicular nerve radiofrequency or neuromodulation using the saphenous nerve, or as a last resort therapy, neuromodulation of the dorsal root ganglia. In acute cases, treatment options include steroid injections, hyaluronic acid, and mesenchymal stem cells, MSC. Genicular nerve radiofrequency is a procedure typically performed in a pain center. It involves applying radiofrequency at 80 degrees Celsius for 90 seconds at three anatomical points: the 𝘱𝘳𝘰𝑦𝑒𝑙𝑎𝑟 genicular nerve, the 𝘱𝑝𝑒𝑟olateral genicular nerve, and the 𝑖nferomedial genicular nerve. The procedure is usually performed under local anesthesia and guided by ultrasound. Anatomically, the genicular nerves are articular branches responsible for the sensory innervation of the knee. Other joints also have similar articular nerve branches that can be targeted in certain cases. Here is how the radiofrequency procedure is performed. Using ultrasound guidance, the artery and the target nerve are identified. Then, a radiofrequency needle is inserted to perform a sensory test before proceeding with the actual ablation. The sensory test is essential to confirm that the needle is positioned close to the sensory branch and not near a motor branch. The lateral inferior approach is usually avoided because of the presence of the subfemoral nerve bundle. Lesioning this area could result in foot drop, making it difficult for the patient to lift the foot. It's important to note that there are many nerves innervating a small joint like the knee, and their exact position can vary from patient to patient. Here is the data on genicular nerve radiofrequency. Over a 2-year period, 50% of patients experienced more than 70% pain relief following the procedure. This slide shows peripheral neuromodulation targeting the subfemoral nerve. It can be used in cases of peripheral transcutaneous analgesia, PTA, with stimulation frequencies above 1,000 Hz. This approach allows for effective control of both neuropathic and nociceptive pain. The electrodes are placed under ultrasound guidance. After 24 months, a significant reduction in the numeric rating scale, NRS, for pain can be observed. The final option, a last resort intervention, is neuromodulation of the dorsal root ganglia, DRG. This is particularly useful in patients with severe pain, where the articular branches innervate not only the synovial tissue but also the bone. The issue is that the bone is not innervated by the genicular nerve, so in these cases, targeting the dorsal root ganglia at L3 and L4 is recommended. L3 and L4 are responsible for the sensory innervation of the bone around the knee. The results are quite promising, although energy delivery can be technically challenging. This technique acts at the central control level of the nervous system, targeting the point where peripheral sensory neurons connect to the central nervous system. By modulating these nerves, you can influence the transmission of primary pain signals, particularly for the knee, which is most often innervated by L3 and L4. DRG neuromodulation is somewhat different from traditional central neuromodulation. It can be performed at low frequencies and can activate C fibers, which makes it effective for both neuropathic and nociceptive pain. Here are the patient outcomes at 12 months. The NRS, numeric rating scale, and VAS, visual analog scale, scores decreased from 8 to 6, and the pain-free walking distance increased from 200 meters to 1,200 meters. So, from past to present, we've seen significant improvements in both pain and functional loss. There's still much to explore in the field of musculoskeletal medicine, and one promising area is the use of mesenchymal stem cells.